Hello, this is David Lederer from Columbia University Medical Center. Welcome to this educational activity on a patient's journey with idiopathic pulmonary fibrosis. I'll be joined today by a primary care physician and one of his patients who has recently been diagnosed with idiopathic pulmonary fibrosis.
The following audio is from a three-part panel discussion with pulmonologist Dr. David Lederer, a primary care physician, Dr. Stephen Antonini, and Dr. Antonini's patient, Robert Brinson. This audio is part of a certified educational activity titled Personalizing Idiopathic Pulmonary Fibrosis Care Through Communication and Innovative Strategies. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/BUF. A printable transcript, slides, practice aids, and other features are also available.
I'd like to start with background about IPF. IPF is defined as a peripheral lobular fibrotic lung disease of unknown cause, and it's actually one of many different kinds of interstitial lung disease. The ILDs are characterized by inflammation, fibrosis, or both of the lung parenchyma, not due to an infection or to neoplasia. It's a disease typically of older adults. About 1 out of 200 adults over the age of 65 are diagnosed with IPF today. And about 1 person out of 1,000 adults over the age of 65 will develop the disease for the first time each year. I consider it to be a high-impact disease. People suffer from disabling exertional dyspnea and bothersome persistent cough. Many people, as the disease progresses, suffer from severe functional limitation and impaired quality of life. And the median survival time is only 3.8 years. Now, in my experience, there are a number of dilemmas in this condition. The clinical dilemmas, it's difficult to recognize and diagnose, and the saying that there's nothing to do for these patients, which is just untrue. There are also public health dilemmas. Many consider it to be a rare disease, which I'm not certain is true. There's a lack of provider and public awareness and limited research funding. And at the biological level, there's so many things we don't know. It's the disease of unknown cause. There are multiple mechanistic pathways that are implicated in animal models, but in humans, we really don't have a lot of data. To understand the patient perspective, as well as the challenges facing our colleagues in primary care, we're fortunate to have with us Robert Brinson, a patient recently diagnosed with IPF, and his primary care physician, Dr. Stephen Antonini. Bob, we'll start with you. Can you tell us about your experience as a patient with your initial symptoms and how the diagnosis unfolded?
I certainly can. Thanks so much for this opportunity to speak with you today. I think if I remember correctly, a few years ago, I was dealing with some congestion in my chest. And it persisted, and I ended up going to my primary care physician, Dr. Antonini, and he suggested that probably the best way to handle it would be to see a pulmonologist. We set up an appointment. They gave me a breathing test down there, and the pulmonologist actually said, I'm going to more or less classify this as wheezing. I don't really know if it's asthma or what, but maybe a over-the-counter asthma medication might give you some relief. And I took it, and it did seem to work pretty good. It really did. And I was fine up until last summer. And at the end of the summer, I noticed that I had developed something that I described as just being out of breath for no reason at all. I couldn't seem to get enough air into my chest, into my lungs. And I went back and saw Dr. Antonini, who again decided that maybe we should do a chest x-ray. And through the chest x-ray, we set up another appointment with the pulmonologist, who suggested that possibly a CAT scan would be the best way to go, and to see a pulmonologist that dealt with lung diseases. And it was that specialist that diagnosed it as IPF.
Okay. And so, Steve, from your perspective as Bob's primary care doctor, what was that like with his presenting symptoms? How did you undergo your evaluation?
He initially saw me 2 years ago, and it was 2 episodes of bronchitis close to each other with some shortness of breath, some wheezing, and some cough. At that point, his oximeter reading was fine. Everything's fine outside of these wheezing. And I thought it was a little unusual because he never had any complaints of lung disease, any symptoms. So I did tell him to make an appointment with a pulmonologist, which he did. Through letters from the pulmonologist, I knew of the diagnosis. Initially, they just called it wheezing, maybe reactive airway disease, allergic rhinitis. But the second letter said presumptive asthma. He was treated with a steroid inhaler. He was given a short-acting beta agonist if needed. And then at that point, I didn't hear from him for another 2 or 3 months when he returned with this symptom that he was talking about, the shortness of breath at rest, this heavy sighing that he would do. He was still saying he could do everything, walk the dog, he was doing everything outside still. His wife was present with him at that time and, giving me, signals and, oh yeah, this is significant, because he seemed to downplay his symptoms. I did an examination on him. Vital signs were fine. His O2 saturation was fine. He did not have, at that point, any crackles or wheezing on examination. So I said, I'm not sure what the sign is, but you're acting fine. And I almost was going to say, well, let's just watch a little longer, until his wife was persistent and said, this is not right. This is happening at home. He's doing this. So I said, okay, let's do a chest x-ray. And I'm fortunate to have x-ray services in my building. So I was able to get it right away. It showed hyperinflation. The radiologist confirmed it. So we decided that he should go back to his pulmonologist.
I will say that that presentation, as you know, is unusual for idiopathic pulmonary fibrosis. Most people present with bothersome persistent cough, exertional dyspnea, and most have crackles on exam. Steve, in your practice, are those common presenting symptoms?
Yes, they are common, but they're more for infectious reasons, cardiac reasons, and also COPD. I rarely think about, interstitial lung disease.
Right. So this would be a good opportunity for me to talk a little bit about interstitial lung disease. We can put interstitial lung disease on the differential when there are these presentations, which include chronic persistent cough that's not responding. Most people presenting with exertional dyspnea don't have interstitial lung disease, but persistent exertional dyspnea that's not explained or only partially explained by other diagnoses should raise a suspicion of interstitial lung disease. Now, less commonly, they might have it because a family member has interstitial lung disease, or because they had a CAT scan of their chest or abdomen for some other reason, and in the bases of the lungs there were extra markings. So my suggestion is that in your practice, in addition to the usual things you might do, that you look, listen, and walk your patient. What I mean by that is to look carefully at their fingers for digital clubbing, which is present in about half of people with idiopathic pulmonary fibrosis. Do good chest auscultation. My recommendation is to listen lower down, more caudally than you might usually listen. That's where the first crackles will start, as well as in the mid-axillary line. In addition, you can walk your patient in the hallway to see if they desaturate more than 3 or 4% after walking maybe 200-300 feet. You could order a 6-minute walk test as an official test. Now, as you're putting your history, your physical, and these test results together, here's a simple way to think about interstitial lung disease and when it should arise on your differential. So if you have one from column A and one from column B, any combination there should really raise your suspicion of interstitial lung disease. And I do think it's important for primary care providers to have a low threshold for investigating interstitial lung disease, because nowadays we believe that early diagnosis can lead to better therapies and avoid some suboptimal management strategies. The next step is to order a high-resolution CT scan, which is what was done in Bob's case, quite appropriately. So high-resolution CT scan is not exactly like a regular old CAT scan for a couple of reasons. So the first is that we do need thin slices or thin collimation, typically less than 2 millimeters, preferentially under 1.25 millimeters will give a nice thin resolution. I do recommend also performing expiratory imaging so that we can look for gas trapping, which would argue against idiopathic pulmonary fibrosis. When the raw data is reconstructed into a picture, a specific algorithm needs to be used, and it's called a high spatial frequency reconstruction algorithm. IV contrast, not required. CT angiogram gives you those thin cuts, but they're not typically reconstructed as a high-res scan, so that's important to think about. Now, I do want to show you a couple of pictures of representative high-resolution CT scans. When we see ground glass and reticulation, we should immediately think of interstitial lung disease, but idiopathic pulmonary fibrosis, unless there's a superimposed process, does not have a lot of ground glass. You can see this patchy ground glass changes, also not going to be idiopathic pulmonary fibrosis. Lower lobe peripheral reticulation honeycombing without ground glass and without other unusual findings is called usual interstitial pneumonia pattern on CT, or UIP. And that strongly suggests idiopathic pulmonary fibrosis unless we can identify another cause of it. So next, we're going to discuss the treatment of IPF, focusing on new therapies that are available for treating this disease, and we'll also talk about the impact of an IPF diagnosis and how we can work together with our colleagues in primary care to provide the best support for our patients with this disease. Welcome back. We've been talking with Bob Brinson, a patient with IPF, who will describe his experiences following his diagnosis. We also have with us Bob's primary care doctor, Dr. Stephen Antonini, who will describe the role of primary care physicians in helping patients cope with their diagnosis and in working with them to improve the management of their disease. Welcome back, Bob and Stephen.
Thank you.
Bob, when we spoke to you in the previous segment, you described the events that led to your diagnosis, but what I think would be helpful is to hear about the impact of that diagnosis and what we can do to improve the care of patients with respect to delivering this kind of news.
Sure. To be honest with you, in spite of it being a very negative discussion that day, I felt that from my perspective, it was so uncomfortable. It actually led me to another doctor, led me to another care center. And ironically, as it turned out, the initial prognosis was spot on, but it was just the way that it was presented, that it was so matter of fact, that it had to do with something, in my estimation, that was so tragic and something totally unexpected. And it was like a throwaway. By the way, you only have maybe 3 years, maybe 5 years, and here's a booklet, and good luck. And it was like, and so I said, can we circle back to the 3 to 5 years as far as the discussion goes? And I said, is that how long it takes to cure this disease? And he said, no, that's how long you have to live, basically. And it was very, very, I can't even describe. It was very upsetting. It really was.
The truth is that no one is that average. Everyone's different. And there are plenty of people who live much longer than that average.
That's what I'm finding. And my second doctor took an entirely different approach, and echoing much of what you've just said.
So Steve, from your perspective as his primary care physician, what was your sense of his emotional state? What were you able to do to help him cope with this?
So he came back 3 months later. Again, I was aware of the diagnosis through the consult letters that he had pulmonary fibrosis. I was aware that you had even talked to a transplant doctor and everything like that. But what I wasn't prepared for is when he came to the office, I think the reason why he came in to discuss results and stuff like that was his emotional change. Having known him for many years, he's a very calm, laid-back, generally a laid-back person, but he was more anxious. He wasn't sleeping. Again, his wife confirmed these issues and so forth. And I said, oh, wow. And I don't know if they picked up on me thinking, oh my God, in my head I'm thinking, wow, that sure went fast. And I said I could pick up on the anxiety. So I said, okay, everything was fine, but I felt he almost had like a reactive sadness from the diagnosis. That was before you had gotten your second opinion, and I thought it was a great idea because somehow it wasn't delivered to you properly or you didn't hear everything. So I offered you medicine, which he took, and it did help you because he came in a couple follow-up visits. But I just thought that was, I wasn't prepared for him to return and even knowing what I should have known I didn't get that feeling from the consult letters. I just, I learned a lot more that day about you.
And I think critically important and often overlooked is trying to focus on the things that aren't necessarily the respiratory symptoms.
Right.
So as you brought up, Steve, focusing on mood and mood disorders and depression, many people with lung disease have anxiety and anxiety disorders that need to be addressed. So of course, the other side of this is treatment options that are pharmacological. And so I do want to take an opportunity to talk about that. We do have two in the US FDA-approved therapies for idiopathic pulmonary fibrosis, and they are nintedanib and pirfenidone. Now, both are not curative, but both have been shown to slow the progression of idiopathic pulmonary fibrosis. And I'll take a few moments to review the data that led to the approval of these drugs. I'll also talk about their adverse event profile. And maybe we'll start with pirfenidone. So pirfenidone is a small non-peptide molecule. It does actually have many different mechanisms of action in vivo and in vitro. No one is certain which of these mechanisms are the therapeutic mechanisms, but I will mention that this drug can inhibit release of pro-inflammatory cytokines, can attenuate fibroblast proliferation, and inhibits release of transforming growth factor beta 1, which is a key mediator of fibrosis, and can also inhibit collagen synthesis. The ASCEND trial was the third major trial evaluating pirfenidone. In this phase 3 study, we randomly assigned 555 adults living with idiopathic pulmonary fibrosis to receive either oral pirfenidone at about 2,300 milligrams per day or placebo for 1 year. And the treatment effect was evident by week 13 and increased throughout the duration of the trial. Supportive analyses of the primary endpoint yielded similar results. The mean decline from baseline in FVC was 235 mLs in the pirfenidone group and 428 mLs in the placebo group. And that difference was statistically significant. Slowed disease progression by almost 50%. Pirfenidone resulted in a significant between-group difference in the change from baseline to week 52 in 6-minute walk distance. And at week 52, a decrease of 50 meters or more in 6-minute walk distance or death occurred in 72 patients in the pirfenidone group compared to 99 patients in the placebo group. That's a relative risk reduction of about 28% in the pirfenidone group. The analysis of all-cause mortality showed fewer deaths in the pirfenidone group than in the placebo group, although the difference was definitely not statistically significant. In the ASCEND and CAPACITY trials combined, pirfenidone reduced the risk of death at 1 year by about 48% compared to placebo, and that was significantly different. The most common side effect is loss of appetite, followed by nausea and vomiting. And there can also be skin side effects. There's a photosensitivity reaction. Grade 3 gastrointestinal adverse events were reported in 15 patients, which is 5.4% in the pirfenidone group, and 4 patients, or 1.4% in the placebo group. And grade 3, which are more severe skin-related adverse events, were reported in 5 patients in the pirfenidone group and 1 in the placebo group, and no one had grade 4 GI or skin-related events. Of note, cough, worsening of IPF, and dyspnea were more frequent in the placebo group. Now, I also have data on nintedanib that I want to present. It's an intracellular inhibitor that targets multiple tyrosine kinases, which may be important in the pathogenesis of IPF. Now, there was a smaller phase 2 trial called the Tomorrow trial that suggested that 12 months of treatment with 150 milligrams of nintedanib twice daily was associated with a reduced rate of decline in lung function as measured by FVC, fewer acute exacerbations, and preservation of health-related quality of life. So this small phase 2 trial led to 2 large phase 3 trials called Impulsus 1 and Impulsus 2. These were identical 52-week long randomized double-blind placebo-controlled trials conducted to evaluate the efficacy and safety of that same dose, 150 milligrams of nintedanib twice daily, as compared to placebo in people living with idiopathic pulmonary fibrosis. Now, between the 2 studies, there were 1,066 patients randomized, 515 were in Impulsus 1, 551 in Impulsus 2. And in both trials, nintedanib significantly reduced the rate of decline in forced vital capacity over the 52-week period. You can see here the between group differences. Again, slowing disease progression by about 50%. The most frequent adverse event in those assigned to the nintedanib group were GI in nature, mostly diarrhea, 60% on drug versus 20% on placebo, developed diarrhea. Most cases were mild or moderate in severity. Now, one thing that I'm often asked is, well, which drug should I use to treat my patient with IPF? And currently, ATS guidelines recommend shared decision-making between the patient, often their caregiver, and the physician. That discussion ought to include discussion about the efficacy of the drug, the safety profile, side effects to expect, in the context of how the treatment will impact on quality of life. It's important to have a conversation to gain an understanding of what contributes to your own patient's quality of life. What are their hobbies? Do they have outdoor hobbies? What do they like to do? How will therapy impact that? It should be a mutual decision. And one of the most important things to do when considering initiation of therapy is to set realistic expectations with your patient. Neither pirfenidone or nintedanib improve lung function, improve walk distance, relieve dyspnea, relieve cough. So we want our patients to clearly understand that the goal of treatment is preserving lung function and slowing the decline of lung function. So Bob, what was that experience like for you when you were having the conversation with your pulmonologist about therapy?
In my mind, I knew exactly what it was, and my biggest question was, what now? How do we attack this? And he said there's a couple of choices out there that have been through clinical trials and have been given FDA approval, and one of them has this side effect, the other one has this type of side effect. And I felt so comfortable with him and his recommendations.
Yeah, sure. And I'll tell you that in my practice, I don't have a preference for one drug or the other. When I look at the efficacy data, they look very similar. They both seem to slow progression by about 50% over the long term. They've never been compared head to head, but that's what it seems like. Right. So I often have that discussion, and then we tailor therapy or the decision to start therapy based on the more kind of nitty-gritty details of side effects and other aspects of the medicine. Yeah. So when we come back, we'll find out how Bob is doing on treatment, and we'll discuss some of the resources available to people living with IPF and talk about the management of IPF patients in primary care. Welcome back. Bob Brinson, a patient with IPF, joins me again to discuss his day-to-day life with IPF and to share his experience with support groups and other patient resources. We also have Dr. Stephen Antonini, who will discuss his experiences in caring for Bob in the primary care setting. Welcome, Bob and Stephen. Bob, maybe you could tell us a little bit about what treatment has been like for you. Tell us a little bit maybe about side effects, how it's impacted your quality of life.
Sure. I'd like to state right away that I'm feeling really very good. I really am. And I'm very thankful for that. I'm not on oxygen. Probably the biggest thing that I'm doing to care for myself is I'm wearing long sleeve shirts. I wear a hat. I use plenty of sunscreen. And I'm getting lots of outdoor exercise. I have a dog. Yes. I think one of the side effects from the drug is fatigue, but I've just turned 70, so I don't think that that's all that uncommon.
How has your experience with support groups with IPF influenced your journey with this disease?
Support groups I can't say enough about. And through the Pulmonary Fibrosis Foundation, we've gotten hooked up with two of them, actually, and we're going to be going to our third support group tomorrow night. And at first, it was a little bit uncomfortable because I saw patients that have this disease that are much further down the road than I am, and you're looking at the future. And to be honest with you, that was difficult at first. But listening to them, hearing their stories, it's actually helped me a lot to understand what I'm feeling. They get it. They understand where I'm at, and now I'm starting to understand what's coming. So,
was this, when you first were told it was IPF, was this an isolating experience for you? Because I hear that from a lot of my patients.
I would say so. I've never heard of the disease. I don't know anybody. I do now, but at the time, I didn't know anybody that had this disease. So a lot of denial going on, really, especially when you feel relatively good.
Sure. And it sounds like the support groups helped address an important need for both you and for your wife.
Absolutely. From the caregiver to the patient, absolutely.
Yeah.
Through the whole process.
Yeah. Stephen, how has your care of Bob changed as a result of his IPF diagnosis?
Well, so far, not too much has changed because, as he said in the prior segment, that things are going well for him. He hasn't required too much. I am still continuing to treat him for his anxiety. He's sleeping better and everything. The only thing I want to know is going forward, since this is a new drug that you're on, I need to be aware of when you're going to be seeing me and when you're going to see your specialist, okay? Mm-hmm. And as long as we can be sure we're coordinating that care.
This is a new area for us. These drugs were approved 1.5 years ago now. So we're still trying to figure out how this triangle fits together and how we're supposed to do it. There are actually a lot of resources at interstitial lung disease programs, particularly those that are Pulmonary Fibrosis Foundation care centers around the country, of which there are now 40. There are nurses who are spending a lot of their time on the phone with patients or working, trying to get them the medications. And then each medication also has some support behind it with nurses who can reach out to the patient from a more centralized resource.
Yeah, I think that would be good because if he does have a symptom, if you could at least talk to a nurse that's associated with the doctor, the pulmonologist, and say, okay, this is okay, you can go see your primary, or you know what, we're a little concerned, we should probably see you. Mm-hmm. So as long as it works that way and I know where I fit in.
And I do want to bring up some of the management tips that I have. So this is what I refer to as an ILD management checklist, and it covers all of the important things, which include talking to your patients about smoking cessation, appropriate use of supplemental oxygen, monitoring oxyhemoglobin saturation using a handheld pulse oximeter at home, ordering, if indicated, a sleep study or performing nocturnal oximetry to assess nocturnal oxygen requirements. When appropriate, enrolling your patients in a pulmonary rehab program, appropriate weight management, which is really important for folks who are going to seek lung transplantation. Of course, age-appropriate vaccination. When available, clinical trial enrollment. I mentioned lung transplantation. You've already heard a little bit about ILD support groups, educational resources on the internet, and for those who are interested, getting involved in advocacy groups. So I would say that one of the biggest challenges for patients living with any form of interstitial lung disease is the transition to using supplemental oxygen initially in their home and then, of course, outside the home. The very common event, of course, is that as people exert themselves with interstitial lung disease, oxyhemoglobin saturations drop, and that triggers that shortness of breath and functional limitation. Oxygen therapy helps address that. So it's important to assess oxygen requirements in the clinical setting, so sitting at rest, walking around with exercise and with sleep, and to prescribe different amounts of oxygen to patients so they can maintain oxyhemoglobin saturations above 90% all the time. So I often prescribe different oxygen flow rates for different activities. I'll often tell my patients to get themselves a handheld pulse oximeter and then to monitor oxygen saturations right after exertion, even little bits of exertion around the home to see how low oxygen saturations go, and then to increase oxygen flows if indicated to help maintain and avoid those saturations below 90%.
David, when should you start oxygen therapy? Is it based on a number on the oximeter? Is it based on patient symptoms?
Typically, early on, no one needs oxygen. As the disease progresses, people need oxygen at night or with extreme exertion. And what that means is that we need to be really aggressive and meticulous about figuring out when people need oxygen. We'll often do a 6-minute walk test or a cardiopulmonary exercise test on a cycle ergometer, or just a simple oxygen titration on a treadmill and increase the speed and the slope until they desaturate and see how low they go, and then give them oxygen on the treadmill to see how much oxygen people need to maintain oxyhemoglobin saturation over 90% during daily activities. So that's rest, that's exercise and exertion. Now, complementary with oxygen therapy is pulmonary rehab or pulmonary rehabilitation. Pulmonary rehab is a comprehensive intervention based on first a thorough patient assessment, followed by initiation of patient-tailored therapies, usually in an outpatient setting. And they include things like exercise training, respiratory and breathing education, behavioral change, designed to improve the physical and psychological condition of people living with chronic respiratory diseases like IPF. Pulmonary rehab can also promote long-term adherence to health-enhancing behaviors. Now, the pulmonary rehab team is often quite big. There's often a medical director who could be a pulmonologist or a physiatrist, of course a program manager, but importantly, respiratory therapists, physical therapists, often a nurse may be involved, an exercise physiologist to help develop the prescription with the physician of what ought to be performed. And then different pulmonary rehab programs can have other resources available depending on unique circumstances, a dietitian, a diabetes educator, nurse practitioner, sometimes a mental health specialist, and sometimes even a pharmacist and a social worker. And I would encourage each provider to steer their patients to the resources that are going to help that patient the best and help support them in a proactive approach to managing their disease. You've already heard about local support groups. The Pulmonary Fibrosis Foundation has many, many support groups around the country, even outside the country now, are these wonderful support groups. There's also online support and online information. There's the inspire.com website, which has an online support group, both for patients and for caregivers, where people can interact and share their experiences. You can also find out more about pulmonary fibrosis at pfresearch.org, patientslikeme.com, curetogether.com, and pfdoc.com that all have wonderful information that'll help everyone understand the disease and provide adequate support and resources. Well, that does bring us to the conclusion of today's discussion of IPF. I do want to thank Dr. Stephen Antonini and his patient Bobinson for their valuable contributions to our discussion today. Bob, as we bring this to a close, I wonder what you would tell other people with IPF about what they could expect or what the future holds.
Two things that I would say is remain positive. You're not dying, you're living, all right? And if you are diagnosed with this, the first thing that I did, and for me, it was a mistake, I went online immediately and I read many horror stories about this disease. It didn't help me. It really didn't. It scared me, to be honest with you, until I had a full understanding of what was going on. It seemed grimmer than the original diagnosis. Which isn't necessarily, as you pointed out, the case. The more people I think that I've gotten involved with my care has helped me tremendously. And in our family, our faith is a big factor of how we're getting through this. And that's it.
All right. Thank you, Bob. So we hope you've found this activity informative and useful to your practice. Thank you very much for participating.
This activity has been jointly provided by the Medical College of Wisconsin and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/BUF. This activity is supported by independent educational grants from Boehringer Ingelheim Pharmaceuticals Incorporated and Genentech.